This mini lecture is going to cover a condition that you might not see real frequently, but on occasion in primary care, which is preseptal and orbital cellulitis. And when you're looking at the periorbital infections, you have to classify them according to where they are anatomically. So with preseptal, it is anterior to the orbital septum, and the septum is a natural barrier. It acts as a barrier against microorganisms that could try to get in there. So preseptal is not as concerning as orbital is. Orbital is posterior to the septum, and the distinction between the two is critical because infection of the orbit with extension to the orbital apex can lead to blindness and even fatality. Both of these are more common in children, but you are going to see them in adults as well. The common cause is from the ethmoid sinuses. So somebody may have a really bad sinus infection and then it extends up into the orbit. So there's an extension of acute as well as chronic. Three sources are present. So local spread from adjacent structures. So something from the sinus and the lacrimal system, or someone who has been inoculated after a trauma, such as a bug bite or a laceration, or somebody who has had bacteria spreading from either a middle ear infection, a heart infection, or even the upper respiratory system. Some of the causative organisms include strep, staph, H. fluenza, and M. catarrhalis. And usually H. fluenza is less common. You don't see it as much because most people are now getting vaccinated by the Haemophilus influenza type B. But M. catarrhalis and the anaerobic bacteria of the upper respiratory tract are sometimes implicated. And if somebody is a diabetic or they are in an immunocompromised state, then you need to consider a fungal cause, which could be from the aspergillus or the mucor. So children usually, I just wanted to bring this up briefly, the majority of children, when they get this, it's either from a staph or a strep. But in patients over the age of 15 or a diabetic or immunocompromised, they're more likely to get the aspergillus or the mucor. In preseptal and orbital cellulitis, you're going to see differences in presentation. So you're going to see where the patient comes in with a warm erythematous skin around the eye, but with preseptal, the way you can differentiate between the two is that the eye is not involved, as there is with orbital, where you're going to see a dramatic appearance of axial proptosis as well as swelling of the lid. They're going to have some difficulty with motility of the ocular as well as in conjunctival injection. So you're going to see that where you will not see that specifically when they do have the preseptal. So as I said, the most important thing to do if somebody presents with eye involvement and you suspect orbital cellulitis is to get them immediate ophthalmic care. So they need to be referred to an emergency room. I wouldn't even refer to ophthalmology because you're going to have to wait to get them in. But I would refer them immediately to the emergency room because you don't want to have them have optic nerve compromise. When doing your physical examination of this patient, you really need to be doing a thorough examination and looking at vital signs, looking at their mental status, because mental status change could be worrisome if they have some type of underlying, maybe meningitis. They may have some neck stiffness, so that could be significant if they are getting a meningitis or sepsis. Visual acuity, wanting to look at their vision, color, pupillary response, extraocular movements, to look at 3, 4, and 11 of the cranial nerves and inspecting the global area for swelling, redness, and pain. If possible, if you can do an intraocular pressure, it would be good to look for that. Most primary care offices don't have the equipment to do that. But it could be measured because venous congestion from the orbital inflammation may lead to those pressures being elevated. So close inspection needs to be done also because the patient may not even realize that they've been bitten by something, and you may be able to find an entry mark on those patients. If someone has orbital cellulitis, most likely you're not going to be doing the diagnostic testing and lab testing in the office. You're going to be referring them immediately. But if they are referred to the emergency room, they can be expected, and you can tell them that they'll probably have a CAT scan of their orbit and the paranasal sinuses with contrast, and they'll also have blood work done, blood cultures done. So that's something that you can tell the patient to expect if they are admitted to the hospital. When you're managing these patients, the management of Preseptal is obviously different than Orbital. As we said, the Orbital, you're going to be admitting them. They're going to be getting IV antibiotic therapy, imaging done. But with the management of the Preseptal, you can go ahead and start them on broad spectrum antibiotics. So a third generation cephalosporin or augmentin clavulanate can be used, as well as going into the doxy, clindamycin, Bactrim, sulfadrug, if you're suspecting that there could be a MRSA going on here. So regardless of the age of the patient, if they are failing to respond to antibiotics, they need to be seen back in the office for possible referral to an ophthalmologist. As you can see on this slide, this is a very classic preseptal cellulitis where the eye is not involved. It's basically the skin around the eye that is significantly swollen and involved, but there is no eye involvement here. As you see here with the orbital, you can see the eye involvement here. And unfortunately, this is, something that's pretty nasty. I mean, it can lead to sinus thrombosis. There can be subdural or epidural, orbital thrombosis, brain abscess, optic neuropathy. There's a lot of things that can occur. So anybody you suspect with eye involvement, do an immediate referral to the emergency room and let them make the decision on what needs to be done. When you're prescribing antibiotic therapy, these patients need to be, or the family needs to be informed that if there's any signs that occur of fever or irritability or lethargy, that the patient does need to go to the emergency room, because then you're really concerned about sepsis or meningitis.